Hello, so in this eLearn 6.2, we're going to be talking about special scenarios with modified treatment, choices, and targets for hypertension. Some of it has been already mentioned in 6.1. By the end of this session, all learners should be able to evaluate for special scenarios which modify treatment and targets of hypertension. At this point, I just want to remind everyone about the concept behind white coat and mass hypertension, which is covered in the earlier sessions. Let me elaborate further on white coat hypertension. Now, anxiety can raise blood pressure as much as 13 mmHg, and this is due to a fight or flight reaction from any normal human being who sometimes either feel threatened or anxious. This very commonly occurs in our old ama and akong when they go to clinics, and I realized that it seems to be a lot more common in old aunties in my practice. So this can occur in both normal tensive or hypertensive patients. Not say you have to be hypertensive in order to develop white coat hypertension. It can affect any age with no real characteristics for you to identify accurately which are true white coat hypertension, and that's really the problem. So for this purpose, you could either order an ambulatory BP monitoring or self BP monitoring, meaning you get them to monitor the blood pressures at home. For the ambulatory BP monitoring, I just wanted to mention that there are machines that can strap patients on, and essentially those are going to be tracking their 24/7 BP readings. And it's expensive, so we don't commonly use it. With respect to mass hypertension, it's the complete opposite, where the home blood pressures are raised and the clinic blood pressures are normal. So this is circumstance when, interestingly, the ABPM is going to be useful because it's something that you cannot ask patients to monitor themselves for, right? You can't be asking them to, wake up at 6 a.m. in the morning just to track their blood pressures or track their blood pressures hourly. So these are various scenarios where either ABPM or SBPM can be useful. And I cannot start to underscore the importance of why it's so important to ask your patients to monitor their blood pressures at home. Let's talk more about the older adults. I'm sure this will struck a chord with a lot of us because we have all ama and akong, right, who are also hypertensive, right? So at this point, I want to remind everyone that being old is not a disease, but it actually means to us that we need to be a bit more careful in respect to our decision making and clinical reasoning around when we start medications, how fast we go, and what choice of medications that we use. So the benefits are still seen in BP lowering, and stroke, because it's an age-related outcome, right, is something that we need to be very mindful of. Remember that an older antihypertensive is 2 to 3 times more likely to develop CV events than younger adults with the same levels of blood pressure. Vascular aging and isolated systolic hypertension and white pulse pressures particularly seem to be important in Asians, and this was postulated to be due to the shorter heights, which I don't know is really an attributable cause for white pulse pressures. That being said, we're talking about stroke risks in Asians, and we need to be very mindful that stroke is a real problem and a threat in Asians, and so blood pressure lowering is very important. White coat hypertension is common as age increases, and home blood pressure monitoring becomes very important. If we recall the story I told you about the 80-plus-year-old uncle who had dizziness each time he takes his 4 antihypertensives, you will remember why I'm saying that home blood pressure monitoring becomes important. Now, orthostatic hypertension and isolated systolic hypertension are very common in the elderly, and we need to be very careful about those with concomitant valvular heart disease, particularly if they had severe aortic stenosis. And this is because people with very severe AS, when you try to use vasodilators on them, because remember the aortic valve is already incompetent and cannot maintain the cardiac output in the form of systolic blood pressure. So if you're going to be overtly enthusiastic about using vasodilators, you're going to end up reducing TPR as well, and therefore causing a profound drop in blood pressure, thereby precipitating hypotension in the elderly patient. CCBs and diuretics are likely to be beneficial in the older adults because of IC6. And IC6 seems to have quite a lot of studies with respect to the use of the hydropyridine CCBs as well as thiazide and thiazide-like diuretics. I think it's also important to remember that diuretics tend to cause hyponatremia in the older adults. And so these are caution points that you might need to think about if you need to ever use thiazides in the elderly. You might need to call them back for blood tests. So remember, take very good note that people who are 65 to 80 years old, stepwise, you might want to target for the blood pressure to be maybe less than 150 millimeters mercury. And if tolerated and achievable, we want to go for 140 over 140 mmHg. And ideally, if tolerated, right, we want to lower them to the same levels as the young adults. Okay, for people who are older than 80 years old, it's very important to titrate cautiously. So we'll compare this against the guideline recommendations of target BPs in the general adult later on in the IC itself. What about considerations in women and pregnancy? Remember that in women, because they tend to use oral contraceptives, it can cause increased blood pressure and is proportionate with the duration of use. Okay, so one of the causes of secondary hypertension, if you recall, is the use of OCs, right? Pregnant women should also be followed up very carefully. And remember this, the indicated therapies for pregnant women are methyl-dopa, beta blockers, and in the previous series, we talked about labetalol, and in some vasodilators. In Singapore, we commonly use the hydropyridine calcium channel blockers that are for patients who have got high blood pressure and who are pregnant. The A's and ARBs are teratogenic, and particularly in the second and the third trimesters, be very careful about using A's and ARBs in childbearing age women. Okay? Now, what about children and adolescents? Now, I can't profess to be an expert, and pediatrics itself is also a specialty, so I can only tell you what I've also read. With respect to hypertension, is defined as SVP or DVP that's above the 95th percentile for sex, age, and height for at least 3 occasions for children. And for these children, there are usually charts that are published for what's considered normal blood pressure appropriate for the age. And that's why we talk about the 95th percentile with respect for sex, age, and height. So if it is in adolescents, then anyone above 120 over 80 millimeters mercury is considered high blood pressure for adolescents. Commonly, when you see people with hypertension, these young people, a lot of them have got family history, and many are also overweight or obese because it's associated with a state of insulin resistance. And also, these people are associated with very high CV risk as well. So it's important to customize evaluation because secondary hypertension is more common in children. It's important to carry out appropriate workup to identify causes of hypertension rather than just treat them with therapies alone. Very commonly, the kidney disease is a very common cause of secondary hypertension, and so we need to be on lookout for children with hypertension or adolescents with hypertension as well.